Everybody, this is Ransom Thomas for Santa Fe College. We're going to be going over cardiac rhythms today. So I'm going to do something a little different with this course. I'm going to break it up into a few different videos. So please leave feedback if you appreciate that, or if you prefer it all in one big long video. So we're going to start with going over cardiac rhythms and just the most basic thing. So when we look at rhythm strips, because mostly what we're going to be talking about and looking at a lot is telemetry strips or EKG strips or ECG strips, electrocardiogram strips, and interpreting the rhythms, and then understanding what is it that we're going to do when we see rhythms we don't like, right? So to understand how to interpret rhythms when you see a strip, we first have to understand what the strip is telling us and how the electrical conduction system of the heart works and how it relates to what's presented on the strip, right? So this is a picture, obviously, of the heart, and this is the electrical conduction system. The place that the conduction begins is this SA node, the sinoatrial node. So that's where the electrical impulse originates, right? It travels down into the AV node or the atrioventricular node. It then travels down the bundle of His, right, which kind of you can think of it as running through, the septum almost between like the left and right sides of the heart. Then we get into the bundle branches, right? So the bundle His breaks off into the left bundle branch, the right bundle branch, and then those branch off into the Purkinje fibers, right? So what's happening is there's cells that are sending out this electrical impulse. And as that impulse hits the individual like myocardial cells, the cardiac muscle cells, they're activating them and forcing them to contract, just like any other muscle, right? So the way to think about it is, or this is how I think about it, might not be the most accurate, but I think it's useful, is the cardiac cells are almost like batteries, and they don't work until they're fully charged. So basically, every cardiac cell, every cardiac muscle cell, before it does its job of contracting, which when they all do it together makes the whole, ventricle or atria contract, they got to reach their action potential, right? They got to like charge up their battery all the way. So when we look at the strip, when we look at the telemetry strip or the KG strip, we're looking at the electrical activity in the heart. Really, we're looking at the electrical activity that the leads can pick up. And we're going to go over the leads in a second. But usually, hopefully, if we're doing our job right and the patient's not like doing something crazy, it should be showing us what's happening in the heart, right? So we're going to talk about the different waves, but it's also useful sometimes to think about the waveforms on a telemetry strip as well, what's happening in the heart at this time, right? So I'm going to mention a couple things, and I'll probably mention it again as we go on because repetition is how you learn stuff. But effectively, we have a P wave, what's called a QRS complex or a QRS wave, and then a T wave. The way to think about those waves, and there's a couple different ways you can, but one way is to think, okay, the P wave is the SA node firing, more or less, right? The QRS complex is the signal getting to like the AV node and the Purkinje, basically going through and hitting all the Purkinje fibers and everything, right? And then the T wave is the heart kind of resetting, right? Another way to think about it, it's probably the more useful way to think about it, is the P wave is the atria contracting. The QRS complex is the ventricle contracting, and then the T wave again is kind of the repolarization, right? So there's just a couple different ways you can think about it. I think thinking about how the heart is contracting is probably the most useful. But yeah, when we start talking about arrhythmias and not so good rhythms, it hopefully will help understand what's going on and hopefully help so that you're not just memorizing, oh, this kind of rhythm, this is the P wave length, this is the QRS length, and this kind of rhythm, this is the QRS length. That's useful. I'm not saying don't learn that stuff, but being able to just look at a strip and understand what's happening in the heart is going to be way more useful to you than just memorizing things, right? Because you can always ask a colleague or Google search something like, hey, how long should a P wave be? And you should probably know that, hopefully. But like, just if worst case scenario, if you didn't, you can look at a strip and say like, hey, something's off about this. I can look and just looking at this, I can tell that there's too many P waves, or the P wave looks too long, or it's just malformed. and understanding that that corresponds to some problem with the electrical conduction system of the heart, and specifically with that beginning, right, in the atria. That's again, hopefully you know all that stuff. Hopefully you do know what a normal P wavelength is. But if you didn't, hopefully that'll kind of be a little more useful to you in actually understanding, okay, what's going on with the patient. So when we look at a telemetry strip or like an ECG strip, this is what we're looking at. This is a blank one, right? Usually when we look at one, we measure them out 6 seconds. So from beginning to end, they're 6 seconds long. And you can do the math on this if you don't believe me, but we segment them off into kind of what we call like big squares and then little squares. So we have these big squares, and then we got the little tiny squares, right? Those big squares, sorry, I'm getting my laser pointer because I don't know if you can see my mouse pointer or not. This is the big square, and then these are the little squares, right? Each big square, as you can see down here, is 0.2 seconds long, which means, and again, you can do the math if you don't trust me, but there's 1, 2, 3, 4, 5 little squares. So that means each tiny square is 0.04 seconds long, right? There's also, it shows here, the voltage. We're not going to focus too much on the voltage. It's not, just saying it's 0.5 megavolts, but it's not, there are things to know and understand about it. But usually when we talk about memorizing and remembering measurements for rhythms, the voltage is not usually as focused on. It's not quite as important. So I don't want to, you know, this video is going to be public. I'm going to try to make all my videos public. So there might be people in the comments who want to tell me that I'm wrong. I'm a terrible nursing instructor, and they're probably right for not only this, but many other reasons. But, you know, we're training entry-level RNs. And so usually the focus is on the lengths of waveforms, not so much the voltage. Although, again, there are situations where the voltage is important and how the waves orient themselves. Typically, again, for us entry-level nursing students, you know, they're just going in to get our RN, it's going to be pretty apparent, right? It's going to be, and I'll go over some examples as we go on to some other rhythms. It's going to be pretty apparent. You're not going to need to memorize like a certain voltage. It'll be like, okay, yeah, this is very clearly, you know, a PVC or something like that. I'm sorry, I got to go to my laser pointer now so I can actually click forward. So this is just breaking down the big squares. Just again, so if you didn't believe me, one of these squares again then is 0.04 seconds, and again if we break down the megavolts, it'd be, you know, 0.5 is each one of these, like you know, big squares. So again, when you're measuring the wavelengths, this is how we measure them. We get to take the paper and we get to squint our eyes and look really carefully, and then yeah, try to figure out like, oh, is that actually in this square? Is it actually starting in this square? And, you know, drive yourselves crazy trying to figure out when probably it's doesn't matter either way. And the length is like going to be, you know, the rhythm is what it is, regardless of where you start measuring it. But anyway, sometimes it can be a little hard to find if you're trying to be really precise. But generally, you know, you can get like a magnifying glass or something like that. There's usually on the floors, they'll have something that you can like get to kind of make it easier. So, whoa, that's crazy, right? We just went from this, which it's pretty easy because there's no rhythms, to now we've got like, you know, a dozen or more rhythms on the screen. So what are we looking at here? So this is a single rhythm strip, right? What you're likely going to see is a single rhythm going on here. This is a 12 lead ECG or EKG or electrocardiogram. And I'm going to go over the leads in a second. I'm going to skip around on some slides. So sorry if I'm giving you whiplash. These are the leads, right? We attach them to the patient. And then what we're actually measuring is the way the electricity flowing from one lead to the next. So you do not need to memorize. And again, somebody can in the comments can chide me and say that actually I'm doing y'all a disservice, but just probably you're gonna be okay unless you're working in specific settings. You don't need to really understand exactly which lead corresponds to which electrodes going to where. So in other words, like lead one, you know, again, I'm not even 100% sure myself, just off the top of my head, but yeah, you have like leads going, the electrical signal going from like here to here, or measuring from here to here, or here to here. And so that's what you're capturing, right? So they're broken down into like lead 1, lead 2, lead 3, lead whatever, AVL, AVF, V1, V2, V3, V4, V5, V6. So these are all the transmission of electrical signals from one lead to the next, right? Typically, when you're looking at a rhythm strip, you're going to see 1, 2, that's usually what we see. And if you'll notice, so the way to read this and interpret this, because again, it can be a little confusing. This is one lead, right? You can even see like where it has the little like kind of hash mark kind of breaking it off. This is one lead, right? This is another lead. This is another lead. This is the start of this lead, right? And it goes to here. This lead, this lead. You see now we're starting V1, this lead, this lead, this lead, V4, this lead, this lead, this lead. Does that make sense? So basically we got 1, 2, 3, 4, 1, 2, 3, right? 4 times 3 is 12. Now, down here at the bottom, you'll notice this one doesn't have these little marks to help us tell where one ends or begins. That's because this is all just one lead, and you'll notice 2, 2. Typically, we get the 2 lead down here nice and big for us, and that's because the 2 lead, the second lead, is usually the one that we're interpreting, right? Not always, but typically. If you are getting a telemetry box, because a lot of people, if they're on cardiac monitoring, they're not getting 12 lead EKGs just continuously, especially on a med surg floor. They'll be having tele, which means there's fewer leads. And they also will usually on the tele box that'll be like with the patient, there might be a screen that you can actually see the lead and display the lead on the box itself. If not, then it'll be up on the nurse's and a monitor in the nurse's station where you can look at it. And that it'll be the case if there is a little screen on the box as well. You'll always be able to see it in the nurse's station. But so anyway, so that's what we're looking at when we see a strip like this. Don't be intimidated. Don't think like, oh my God, I don't know what all this means. Think about it like, okay, I'm going to look at this lead, or the 2 lead. I'm going to go to the 2 lead. That's kind of like a good safe bet and just like look at it and see like, okay, what can I interpret from this? Now, something else to remember is if you look, so this is the same length of time. This is the same 6 seconds being displayed for each one of these leads, right? So it's not like this is one lead and then it switches over to this new one. And you can, yeah, kind of tell that just by looking at them and how the waveforms work and how they match up to each other. So it's not like this is one continuous thing, and it's switching between leads. This is the same length of time, same length of time, same length of time, everything. You'll also notice that depending on the lead, the waveforms can look pretty different, right? Like this one looks way different than this one. And that's because, again, what's being measured is the conduction of electricity through the heart from where one electrode is to where the next electrode is. I almost forgot the word for electrode for a second. I wanted to say lead, but the lead is really the, the transmission. So from one electrode to the next. So in some of them, because of the orientation of the electrode and because of the way the conduction is happening in the heart, it's going to show different magnitudes for the electricity that's being transmitted. So again, you don't need to necessarily memorize what like all these different leads look like in terms of their magnitudes. That's why I kind of focus more on the length of the waveforms, because that is going to be consistent. Now, it might be sometimes hard to see, right? So for example, this one, it's kind of hard to find the P wave. It's kind of hard to find even any of the waves. But if you look at some of these others, this looks radically different than this. However, you can still measure the waveforms, right? Same thing here. Generally, though, the 2 lead is what we use. So if we, and you can see, again, that's why we default to it. So it's probably way too much information. Sorry if I spent too much time on that, but just so you're not intimidated. So this is the way, again, we connect the electrodes. So set them up like this, and then leave the patient on it for a little while. It captures the strip. If somebody's presenting to the emergency room or something like that, they might have these leads put on and they get a 12 lead ECG. just as a snapshot, and then we remove all the leads. Sometimes they'll leave them on. Typically, if they're going to leave them on, they'll put them on like a 5-lead tally strip. That's usually five electrodes basically. So they'll have like 3 leads or 5 leads. Will be the type of monitoring they'll be on. This is an example of the three electrodes, and then the 5 electrodes. Sorry, the image quality is a little grainy maybe on this one. It's not good compression, I guess. So, and again, this is kind of illustrating to you how the electrical impulse traveling from the RA to the LA lead electrodes, that gives us lead 1, right? And so that's just kind of illustrating what I mentioned before about the leads are representing the electrical impulse traveling from one to the other. This is the 5 electrodes, so this would be again, probably a 5 lead, it could be 3 lead or something. Just a little device that you can remember for when you attach these, because my experience on the med-surg floor is the most common ones you'll see are these 5 electrode tally strips or tally monitors. There's little mnemonic devices. Now, obviously, it'll also say on the packaging and stuff where you're supposed to place things, but the colors are supposed to go in specific places or they don't work, right? So white's here, black's here, brown's in the middle, green and red. And the little way you can remember it that I was taught, and if it helps you, great. Black is smoke, red is fire, smoke over fire. White is snow, green is grass, snow over grass. And then brown's just in the middle, or if you can think of it as earth, which I guess centers us all or something, you know, if you want to think of it that way. But yeah, brown just goes in the middle. The leftover goes in the middle, basically, however you want to think about it. All right. So I know we just looked at that crazy 12 lead. Now we're breaking it back down simple for us again. So this is a nice illustrated, labeled everything example of a normal heartbeat represented on a telemetry strip. So first thing, this basically straight line that you can see, it has the little dash line through, calls it the baseline. You can also hear it called the isoelectric line. So the isoelectric line, that's basically 0.0 on your x-axis, right? So moving across, that's the isoelectric line. As we go, as something actually happens in the heart, instead of staying on the isoelectric line, our strip is going to show us different magnitudes, right? So the first thing we should see is a P wave. Now this P wave, as I mentioned before, this represents the atria contracting. From the P wave, we get to what's called the QRS complex. Now each one of these sections, so the Q is here, the R is here, the S is here. Each one of those is its own unique waveform. However, we do not usually worry about interpreting, you know, the Q wave or the R segment or the S segment on their own. We usually look at the entirety of the QRS segment, because the QRS segment taken as a whole, this is, you can associate this with ventricular contraction. This is a ventricle contracting, right? When you see that, that's what you want to think about. You see a P wave, atria is contracting. You see a QRS complex, the ventricle is contracting. And then this last one is the T wave. The T wave is the heart it's repolarizing itself. The way to think about this is the heart is basically an organ that's just a bunch of muscles pumping blood. So this is, you know, the brain telling the muscles, hey, let's go do the deadlift we're about to do. This is doing the deadlift, right? It's a lot of work. And then this T wave is like, you drop the weights on the ground and you go, whew, I don't want to do that again. Except then, you know, in like another second or two, you're gonna have to do it again and do it 100 times a minute for the rest of your life. But that's kind of what's happening here, right? And then there are different segments that we sometimes use to measure different things. So the PR interval is the distance from the beginning of the P wave to the start of the QRS complex. So I know it says the PR interval. It's usually, it's the start of the QRS. The PR segment, which is just from the end of the P wave to the beginning of the QRS. The QT interval, which is from the start of the QRS to the end of the T wave, and then the ST segment, which is just the space between QRS and the T wave. So you'll use these for different measurements sometimes. Yeah, it's kind of depends on what you're looking at and what's happening with the heart. The big thing again though is remembering, okay, what's the length of the P wave, what's the length of the QRS, what's the length of the T wave. These segments, if they're longer or shorter, that can also be a problem, and so we'll go over some of those differences as well. So the P wave, again, the P wave represents atrial contraction. It's the start of the telemetry or the start of the heart contraction. The length should be less than 0.12 seconds. So that's how long we want the P wave. Anything longer than that indicates there's maybe something wrong with the P wave. There's something wrong potentially with the atria, right? QRS complex. So again, we have the Q wave, the R wave, and the S wave. So the Q wave, and this was on the previous slide, so I'm kind of explaining stuff you've already seen, but that Q wave is a small negative dip down the isoelectric line. Sometimes you won't even be able to see this on the strip. And that's oftentimes also why we just kind of group the QRS together, because it can sometimes be really challenging, depending on the lead you're looking at and what kind of monitoring they're on, to actually break down and see where's the start and end of the Q wave, where's the start and end of like the R wave, the S wave, whatever. So the Q wave is the dip below the isoelectric line. The R wave then is ventricular depolarization. And it's a positive, positive like electrical signal, right? So that's when this happens. This is effectively the ventricle contracting, right? And then the S wave is a final small negative dip that kind of comes off the ventricles depolarized. So again, we usually look at the whole complex. We don't look at each individual part, but there might be situations where you height. The length, which I've spelled wrong somehow, is 0.08, 0.10. That's what your textbook says. Less than 0.12 is normal. Greater than 0.12 is too long. So less than 0.12, that's fine. Greater than 0.12, that's way too long. Again, your book says 0.08 to 0.10. You'll find different resources. I'll give you different answers. So I'm not trying to confuse you. That's why I put this in bold. Good thing to remember, just less than 0.12, we're good. Greater than 0.12, not so good. The T wave. Now the T wave is the last bit of the individual heartbeat. This represents the repolarization of the heart. It's getting ready for the next beat, basically. And it's usually a positive polarization above the isoelectric line. So it's just basically the heart saying like, all right, let's get ready for round 2 or around 58 or 70 or whatever it's on for that minute. The length is pretty long. They can be pretty long, between 0.1 to 0.25. So they can be as long or longer than a whole big box on your rhythm strip. The T waves also, depending on what you're looking at, it can sometimes be difficult to differentiate between T waves and P waves. That is something sometimes that students struggle with, especially with rhythms that are, we're going to go over, but like things like atrial fibrillation, there's some others, but sometimes students struggle to kind of differentiate between them. Some just little bits of advice I can say. Usually the T wave has a higher magnitude than the P wave. Not always, but it should usually. It's also, again, longer. Something else that I want to point out, and it's going to come up as we go a little bit longer, as we go over some other rhythms of, well, some arrhythms or arrhythmias, some like dysrhythmias. So come up again, and hopefully you can kind of use this to maybe figure out some of them on your own. Something to remember is that what you're looking at when you see this printed out on your tally paper, this is monitoring the electricity that's being conducted through the heart, right? So you see a P wave, okay, and you see a QRS, and you see a C wave. So there are some rhythms that can develop, and this ties into why I was mentioning about sometimes it can be hard to differentiate between a T wave and a P wave. There are rhythms that can happen where you have a lot of electrical activity happening all the time in the heart, right? So I mentioned atrial fibrillation. I'm just going to kind of give a little bit of a preview to that. Atrial fibrillation means the atria is fibrillating. It means that instead of giving nice big beats, it's kind of like quivering, right? It's just kind of, it's not doing a full nice big contraction. So oftentimes, what we're going to see on a rhythm strip as a result of that, and spoiler alert, I guess, for when we go over atrial fibrillation, is it's going to be kind of like a zigzag. You're not going to see a nice P wave and then a QRS. You're going to see just this, right? You're going to see almost constant P waves. They're not going to look like nice P waves. There's going to be constant, like little jaggedy or even like wavy lines, then a QRS, and then maybe you'll see a T wave, right? The thing to think about is when you see those little P waves, those kind or half P waves, or defibrillating of the atria, you're going to see them, and then you're going to see a big QRS. When you see that big QRS, right? Thing to think about is that quivering of the atria. It doesn't stop, right? It's not like the atria is like doing this number where it's going like, oh, I'm spazzing out, I'm spazzing out. Okay, I'm going to let the ventricle contract, and now I'm going to go back to spazzing out, right? It's going to be like spazzing out, and then the ventricle is going to contract as it's going, right? So, and hopefully y'all like my jazz hands that I'm doing to illustrate this. What that means is, and why that's important is when you look at at any lead of a telestrip, it's showing you only like the maximum voltage that it's picking up from those electrodes. So you're not going to see those little atrial fibrillations that are happening as when the atria is fibrillating at the same time as the QRS. You're just going to see the QRS complex. Now, the reason I mention that is, and the reason it's important to understand that is you can have wavelengths sometimes override each other, right? You can have P waves and T waves happening at the same time, for example. Like they could be, or it can make it harder to distinguish which one is which if they're close together, if they're kind of overlapping. It can also sometimes make it hard to tell if, if a P wave's riding too close to a QRS, especially with something like atrial fibrillation, things like that. So I'm just making you aware of it to understand that when you see a rhythm strip like this, you're seeing the maximum voltage that's happening in the heart at any one moment, right? So when you see a QRS, if they're in atrial fibrillation, for example, it's still fibrillating. It didn't stop, right? And it's not the most important thing maybe to understand that with AFib, but there's some other situations where it might be important. And it's more just, again, understanding what it is we're looking at and how these rhythms work, how when you look at a strip, like what you're actually looking at and how to actually go about interpreting it. So to sum up, I'm going to give you a little preview of the next couple of videos we're going to do, and they should be in a channel after this one. But the rhythms you're going to need to know that we're going to go over: normal sinus rhythm, sinus bradycardia and tachycardia, asystole, ventricular fibrillation, ventricular tachycardia, supraventricular tachycardia, premature ventricular contractions, atrial fibrillation, atrioventricular blocks. So those are all the rhythms we're going to go through in this course. Those are the ones you're going to be expected to know for the exam. Those are the ones you're responsible for understanding. These are also the ones, as far as I'm aware, that you're going to want to know for the NCLEX. These are also the ones you're going to want to know for just life and taking care of patients and making sure you don't miss a rhythm that could be lethal or something. If you work in a cardiac unit or acute care settings, maybe like ICU level or emergency room, or some kind of focus in cardiac medicine or cardiac surgery, there's going to be more than this you're going to need to know, and you're going to need to be able to differentiate between some rhythms that I'm not going to spend a lot of time differentiating between. So for example, when we get to these atrioventricular blocks, what we call AV blocks, there are different types of AV blocks, and they manifest themselves and look differently, and they have some different treatments, and they also are different in terms of their severity, right? How bad they can be for the patient, what kind of treatment they need, et cetera. We're going to be focused on mostly just, hey, what are they? How do we know what they are when we see them? And yeah, how do we treat them? But we're not going to, this isn't ACLS class. This is, again, intro level ASN nursing class. So we're going to go over them, what they mean, what they look like. But I'm not going to necessarily expect you to be able to differentiate between first degree AV block and third degree, or like first degree and second degree AV block or something like that. More just understanding, all right, what are they? what would they look like? How would they manifest themselves? And then generally, how do we treat them and stuff? So yeah, so when we start back, we're going to be going through these one by one. Hopefully this is a good overview. If not, please leave feedback so I can get better and so that my students can learn from your wise comments and ideas you have, as opposed to my bad ideas that I put in this video. So thanks. See you again in a second.